This module, I would like to give you an overview on obstructive sleep apnea syndrome. As you all know, sleep apnea is a very highly prevalent condition which is potentially life-threatening not only to the patient but also to the others. It can be very easily diagnosed, at least in clinically significant disease patient, and it is very easily treatable. What I am going to do basically to give you a definition of sleep disordered breathing, what are the different types of sleep disordered breathings, what is its epidemiology, pathophysiological mechanism responsible for development of apneas and hypopneas, clinical presentation, consequences, diagnosis, and finally, what are the different treatments available to us. First, we go into the definition of obstructive sleep apnea. As you all know, any breathing which results in sleep disruption is called as sleep disordered breathing, and there are different types of disordered breathings which one can see in these patients. They can be in the form of apneas, hypopneas, respiratory effort related arousals, or simply changes in their heart rates as well as blood pressures. Now, most commonly seen disordered breathing forms are apneas. As you know, that sleep disordered breathing is caused by partial or complete collapse of upper airway during sleep as a result of pharyngeal dilator muscle relaxation. Now, apnea is basically a complete collapse or complete cessation of airflow for more than 10 seconds in a patient. This may be associated with significant desaturation and arousal, but for the definition of apnea, these criteria are not included. On the other hand, hypopnea is the result of partial collapse of the upper airway and is associated with decrease in more than 30% of flow from the baseline, which should last at least for 10 seconds and should be associated with at least 4% desaturation or 4% oxyhemoglobin desaturation or an arousal. So, if you see here in this polysomnogram, you can very clearly see where you have the red bars that there is a complete cessation of flow, and then this is terminated by arousal, and then patient breathes for some time and again there is no flow, and then there is an arousal, and this is also associated with significant desaturation, as you can see in green bars here. So, this is a typical case of obstructive apneas. On the other hand, in this case, as you can see in the pink bars, there is a partial reduction of the airflow. These are typical cases of hypopnea, where you see a shallow breathing. Basically, the airflow has reduced by more than 30% during sleep, which is lasting for at least 10 seconds or longer, and is associated with either fall in the oxygen saturation. Here you can see again in the green bars, and or it is associated with an arousals. So, here is something what you see a mixed apnea. Here what you see that there is a complete loss of flow, but there is in the initial part you can see that there is no effort, but then it is followed by effort. So, initial component what is we call as the central breathing, where there is no flow and no effort, and in the later part there is no flow but there is an effort. So, this kind of disordered breathing we call as the mixed apnea, and is usually a part of obstructive breathing only, and is associated with the compensatory hyperventilation by these patients in between the apneic episode, so that they are able to decrease their carbon dioxide levels below the apneic threshold. And so, the pathophysiological consequences of mixed apneas are almost similar to that of obstructive breathing. Now, here you see that there is no frank apneas, there are no frank hypopneas, but what you see that in the flow there is a flattening. So there is a flattening. There are few cycles of breathing which are where the flow top is flattened. It does not fit into a typical hypopnea or apneas, and then it is followed by an arousal. So this is what we call as respiratory effort related arousal. We call it as a sequence of breaths characterized by marked decrease in the airflow for at least 10 seconds with increasing respiratory effort, no desaturation, but which leads to an arousal. So the important thing is that there is an increasing effort in this. So ideally speaking, to make a diagnosis of respiratory effort related arousal, you need to put in an esophageal pressure monitoring device and demonstrate that with each breath there is a progressively increasing negative esophageal pressure. But since it is an invasive process, we can actually make this diagnosis by the use of nasal pressure transducer, in which we can actually show the pattern of the flow. You can see the flattened flow, and which we call as flow limitation. So it is a surrogate for what we see actually as respiratory effort related arousal when we are using esophageal pressure monitoring. So you have three basic types of sleep disordered breathings: apneas, hypopneas, and reras. So when you combine apneas and hypopneas, we call it apnea-hypopnea index, or when you combine apnea, hypopnea and reras, respiratory effort related arousal or flow limitation, we call it respiratory distress index. So sleep disorder breathing is actually a spectrum of disorders. Here on one side of the spectrum you have a patient who is normal, who has no evidence of partial or complete obstruction of the airway, and then a person with the slight obstruction of the upper airway during sleep, which we have snoring. The snoring can be intermittent or regular heavy snoring, which we call as habitual snoring, and then you have only respiratory effort related arousals, reras, but there is no apneas, hypopneas. We call them as upper airway resistance syndrome, and then we have classical sleep apnea hypopnea syndrome, and when you have combination of these two, and finally what we call as sleep hypoventilation syndrome, in which the patients have, along with having apneas and hypopneas during sleep, they have daytime hypoventilation evidence in the form of increased carbon dioxide levels and low oxygen levels. Now this spectrum may present as the main, one of the abnormal component of the spectrum, maybe the main presentation, or in a particular patient over the period of time there may be a progression of the disease from, say, upper airway resistance syndrome to frank apnea hypopnea syndrome with the gain of weight and with the increasing age over a period of time. Now, after the definition, we talk about epidemiology. What exactly is the magnitude of this disease in the community? What is the burden of the disease? That is very important to know. You will see that, as I mentioned to you in the opening remark, it is a highly prevalent condition. And a number of epidemiological studies have been done, not only in India, but abroad. What we see in the one of the original studies by Terry Young in 1993, what they found that about 25% of the males have, US men have apnea hypopnea index of more than 5, and when you combine this apnea hypopnea index of more than 5 with symptoms of excessive daytime sleepiness and fatigue or tiredness, then this was something to the tune of 4%, and in women only sleep apnea hypopnea syndrome of 9%, and sleep apnea syndrome, that is with symptom, was 2%. So this is the first study which was done at a community level, which showed using polysomnography that the disease is quite prevalent. In fact, the symptomatic disease, although was found in 4% men and 2% of women, but asymptomatic disease was seen in almost 25% of men and 9% of women. In India, we have done some studies and we have found that the disease prevalence is something around 5% in children, 5% in adults, and in elderly it is about 9.9%. So there is a male-female difference in the adult population, but in children and elderly there is no significant difference between males and females. So in the reproductive age group, there is a significant difference between men and women. Maybe the testosterone plays a role in the causation of the disease, or in ovulating women or childbearing age, the estrogen may be protective for these women from developing obstructive sleep apnea syndrome. Now, this is a very, very important study which has been published very, very recently, which shows that about 15% of the general population had untreated obstructive sleep apnea syndrome, and these people have, majority of them have no symptoms. So, and this 15% of people have moderately severe to severe disease, which has significant long-term consequences in terms of cardiovascular diseases and other metabolic problem. So this is a big problem. That means patients with moderate to severe disease and not having symptoms, a difficult problem of finding them in the community. That means you need to have lot of screening strategies to pick up these patients. The another thing is that the prevalence of sleep disorder breathing has been increasing over the period of time, and this is what you have seen in the Wisconsin's sleep cohort study, which began somewhere in the 80s, and what you have seen that over a period of 20 years, there is a significant increase in the prevalence of these diseases, indicating the ongoing epidemic of obesity. What are the common risk factors which are associated with sleep disorder breathing? Obesity, as I just mentioned to you, is the most important risk factors. Age, male sex. As I mentioned to you that there is a significant difference between male and female, something 2:1 in the childbearing age group. But after menopause, the prevalence almost becomes equal, and that's where I think the testosterone has a significant role to play. Even if you look into the ovulating females, particularly those with polycystic ovarian syndrome, who have significantly high levels of testosterone, the prevalence of sleep disorder breathing have been found to be much higher in these PCOS women than the normal ovulating women of the same age. This thing. The other important risk factors are alcohol and smoking. Here you can see that as what you can see in the denominator, the neck circumference, which is a representative of central obesity, and as you can see that as its value goes above 100%, there is a linear increase in the severity of sleep disorder breathing, as shown by percentage fall in the oxygen saturation during sleep. Now, who are the people who are more likely to develop obstructive sleep apnea? In other terms, what are the common comorbidities which we see in patients with obstructive sleep apnea syndrome? This may indicate that either sleep disorder breathing is somehow contributing to the development of these comorbidities, or it may share common risk factors with these comorbidities. That the common risk factor can be obesity. The obesity may be associated with sleep disorder breathing and also with hypertension and with diabetes and with other kinds of comorbidities. So if you want to screen patients with obstructive sleep apnea from a high risk population, then you would be looking into patients who are obese, particularly those with BMI more than 30, those who are having significant cardiac disease in the form of congestive heart failure, atrial fibrillation, refractory hypertension, and those with metabolic disorders like diabetes mellitus, impaired glucose tolerance, insulin resistance, patients with pulmonary artery hypertension, CVAs, particularly strokes, post-strokes, and you should also, since sleep disordered breathing is associated with lot of sleepiness and consequences like road traffic accidents, so those people who are involved in high risk drivings, these are the patients should be screened for presence of sleep disordered breathing, and also patients who are undergoing bariatric surgery. So these are the group of patients one has to see. Now, what is the pathophysiology? How does sleep apnea occurs in this 10 to 15% of the people, or what protects other people from not developing sleep disordered breathing? Now, we know that there are multiple factors which are responsible for the development of sleep disordered breathing. The pathophysiological mechanisms are quite complex, and the exact factors or mechanism are not very clearly understood. But however, there are certain things which we observed in many patients. First of all, the anatomical factor. We know that majority of patients who have sleep disorder breathing have anatomically small pharynx. That means they have anatomical structures or abnormalities which results in a small pharynx. So when the pharynx is small, it is more likely to collapse as well as narrowing or closure. So there are factors which normally compensate for this deficient anatomy, and that is the enhanced activity of pharyngeal dilator muscle activity. So those patients normally who have anatomically small pharynx, they keep their pharynx open during the daytime, during the waking hours, because of the compensation by overactivity of the pharyngeal dilator muscle. And this can be seen here, as you can see that in this X-ray picture, very clearly on the left side you have a normal person, and on the right side you have a person with sleep disorder breathing, and you can see the lumen behind the nasopharynx and behind the tongue. There is a significant narrowing in this patient, and if you also look into the chin bone and the angle and the hyoid bone, so there is a significant retrognathia and other abnormalities of the hyoid bone position, which makes this patient vulnerable, and you can see the anatomical changes. So the various other anatomical factors which we see, as we say that this disease is more common in obesity, so there is an increased fatty tissue deposition in the lateral walls of the pharynx. There is retrognathia, small mandible, variation in the craniofacial structures, long soft palate, long uvula, large and bulky tongue, uvula, and tonsillar hypertrophy. So all of these contribute to the development of anatomically small pharynx. So how does this deficiency is compensated? As I mentioned, during the waking hours, the pharyngeal dilator muscles actually compensates for this thing, and this can be seen here. You can see the pharyngeal dilator muscle activity normally in controls which are normal people and those who are obstructive sleep apnea patient, and you can very clearly see that the baseline pharyngeal dilator muscle activity during waking hours is significantly higher in obstructive sleep apnea patient than in the controls. So that's how these patients breathe and keep their upper airway open. But what happens when this patient goes to sleep? So if you see here that the pharyngeal dilator muscle activity is actually controlled by a negative pressure reflex. So normally in the pharynx wall there are negative pressure receptors which get stimulated whenever there is a increased flow or negative pressure when the patient is breathing. So we know that people who have anatomically small pharynx will have a much higher flow through their pharynx and will create more negative pressure in their pharynx. So with the result, these negative pressure receptors will be stimulated, and that results in a reflex arc and cause an enhanced activity of genioglossus muscles. Now what happens to this reflex activity in sleep? So here you can see on the left side, the person when he is awake, And if you give a negative pressure stimulus in the pharynx, you can see that genioglossus muscle activity has markedly increased. Whereas on the right side, you can see that when the person is in non-REM sleep, if you give a negative pressure reflux, there is no increase in the genioglossus muscle activity. So this negative pressure reflex becomes significantly impaired in sleep in patient with sleep apnea patient, and with the result they are not able to compensate for deficient anatomy in sleep, and with the result there is an anatomical narrowing and they develop partial or complete closure of the upper airway. So most of these people have anatomically small pharynx and inability, and they have their inability to maintain the enhanced activity of pharyngeal dilator muscle activity during sleep. Now there are some other mechanism also which have been mentioned recently, which may be contributing to the pathophysiology of obstructive sleep apnea. This could be the degree of arousal threshold, because normally when you develop upper airway obstruction, when you develop hypoventilation, there is an increased effort to breathing in response to hypoxia, hypercapnia, or increased effort because of the narrowing and loading of the system. So with the result, when the effort increases to a particular level, person wakes up. And when they wake up, the pharyngeal dilator muscle activity returns, that of awake state, and their pharynx opens up. So that's the way the apneas and hypopneas are terminated in patients with obstructive sleep apnea, that is with the arousal. Now, how quickly this arousal develops in response to this loading or this narrowing depends on, would decide the length of apnea. So those patients who have a lower arousal threshold will develop arousal to a small loading, with the result they may not develop apneas or hypopneas, and they may have RERAs. On the other hand, people who have a very high arousal threshold may have prolonged apneas or hypopneas and may have significant desaturations of this thing. So arousal threshold, which is genetically predetermined, can decide the clinical picture or clinical phenotype of obstructive sleep apnea. The another thing is what we called as a ventilatory loop gain. What is a loop gain? Actually, it is a measure of stability of negative feedback control system, because we normally respond to changing ventilation, which is represented in the form of hypoxia and hypercapnia. So for a given hypoxia and hypercapnia, there is a ventilatory response. But there are some people, genetically, they may respond more than the normal response, and they tend to hyperventilate for a given change in the carbon dioxide level, with the result that they actually overshoot in their ventilation response and result in much lower levels of CO2, and their CO2 level may actually go below the apnea threshold, and they may actually develop central sleep disordered breathing and instability of their sleep. So ventilatory responses are also important factor which may contribute to this thing. So this way you have these patients who may have very unstable breathing, and that may result into sleep disordered breathing. So this can be manipulated with the use of oxygen therapy or with the use of acetazolamide. You can actually manipulate their loop gain. So after going through the pathophysiology, let us go into the clinical presentation. Now most of the clinical presentations which we see in this patient is basically the result of sleep disruption, which will be seen in the form of excessive daytime sleepiness or fatigue or tiredness or poor cognitive function. And the second part is because of the oxygen desaturations, and these desaturations will have pathophysiological impact on long-term cardiovascular complication. So here you can see that you have daytime symptoms and you have nighttime symptoms, and the nighttime symptoms are basically loud snoring, choking, gasping, breathing pauses, because when they develop apneas, there will be pause in the snoring, and then when there is arousal, there is actually snorting and resumption of the breathing. So loud habitual snoring, choking, gasping, a lot of body movements, periods of silence followed by loud snoring. So these are the important restlessness, are the important this thing. Many people who have something like RERAs, they may not have apneas, hypopneas, they may have lot of arousals, and these patients may actually complain of insomnias. Snoring is usually underreported in many patients, particularly the female patients, and they may actually go to a psychiatrist with basically psychological and psychiatric symptoms of insomnias, depressions, fatigue, tiredness, a picture like fibromyalgia. So that's the way they may present and maybe misdiagnosed, or their diagnosis may be delayed. On the other hand, because of this poor sleep, these patients will wake up with headaches, they will wake up with non-rested sleeps, they may have excessive daytime sleepiness, they have personality changes, intellectual changes, and erectile dysfunction. So these are the prominent daytime symptoms which are associated in this. Patients. Now, what are the consequences? As I mentioned, these excessive daytime sleepiness and desaturations are associated with certain consequences. Sleepiness, which is one of the most important symptom in these patients, is associated with very high incidence of motor vehicle and occupational accidents. These patients have cognitive impairment, they have a poor quality of life, so they are not able to perform or concentrate, they have a low attention span, able to carry out their work effectively. The long-term cardiovascular consequences, as I mentioned, are due to desaturations is hypertension, coronary artery disease, strokes, congestive heart failures, and arrhythmias. So there are large number of observational studies, longitudinal observational studies, which have seen that patients who have untreated moderate to severe obstructive sleep apnea are at a much higher risk of developing both fatal and non-fatal cardiovascular events. And in these patients, they have seen that those who are treated with CPAP, there is a significant reduction in these events. So there is a clear evidence from the large longitudinal observational studies of the long-term cardiovascular complication of obstructive sleep apnea. Although some recent randomized control trials have not been able to show the impact of CPAP in reduction of these morbidities, but in majority of these cases, what we have seen that they were already suffering from these conditions, and moreover, the compliance to CPAP in these patients have not been very satisfactory. Besides cardiovascular complication, you have metabolic problems like insulin resistance, diabetes mellitus, dyslipidemias, and overall, these patients have much more incidence of hospitalization, they have prolonged hospitalization, they have more complications, they have much more residual disability after they are discharged from the hospital. So overall, there is a significant increase in the healthcare cost, and on long-term basis, they have increased mortality, particularly in the moderately severe to severe group. Thank you for your kind attention.